the only show focused on Stars improvement strategies and the leaders who implement them. This is the Rising Stars with Rex Wallace Show, brought to you by Hyperlift.
Hey everyone, welcome back to Rising Stars. I'm your host Rex. This is Mick. Hey Mick.
How you doing, Rex?
Hey,
Thank
man.
you.
So hey, here we are, the first week of April. Right, we received the final rate announcement on Monday. We're waiting on the final rule. So some known, but still a whole lot of unknown. So based on what we do know, we want to spend today with a couple of special guests talking about what I think is the most important strategy in Stars right now, given what we do know. We talk a lot, Mick especially, his company talks a lot about the improvement measure, how to leverage it, how to maximize those 5 weight measures. And now with some of the other changes coming, with the loss of the reward factor, which is an enormous change for high performing plans. With this health equity index reward coming into play that we still don't know a ton about, right? We know the program design, but it's not in play yet. So until we see it, I think there's still a learning curve that we're going to all climb over the next couple of years, right? But we want to talk about some really important concepts that tie all of that together. Our guests today one is a returning guest, Nate Lucena. Nate is the Chief Strategy and Analytics Officer for RWC. Welcome back, Nate.
Hello.
And then we have, and I'll let you guys introduce yourselves a little bit more in depth in just a second. And Brendan Generelli is a new guest on the show. Brendan is the head of Stars at Blue Cross Blue Shield of Rhode Island. Perennial high performing plan. 5 stars the last couple of years, 4.5 this year. Hoping to get back to 5, I know. So with that, so Brendan, thanks so much for coming on. With that, we'll maybe you go first, Brendan. Will you give a little bit more in-depth introduction of yourself for our listeners?
Sure. Thanks, Rex. So my name is Brendan Generelli. I'm the lead program manager for Stars and Quality at Blue Cross Blue Shield of Rhode Island. I've been working at Blue Cross for 12 years in a variety of roles, but really started in the star space about 6 years ago. Like Rex mentioned, in 2022 and 2023, we did hit 5 stars on both of our contracts. In 2024, we hit 4.5 on both of our contracts and are trying to claw our way back up to 5. I also, have a really deep tie into the health equity work that we do here at Blue Cross Blue Shield of Rhode Island. And I think this topic that we're going to be talking about today is very important and very interesting. So looking forward to the conversation.
Yeah, so glad to have you. We've gotten to know Brendan over the last, couple of years, I guess, right? Through conferences and other things. And yeah, I found Brendan to be one of the most knowledgeable Stars leaders in the country right now. Especially around these topics that we're going to talk about today. So I'm really excited that everyone will get to hear, some of Brendan's insights here. And then Nate, will you give a quick, little bit more in-depth intro for you?
Sure. Nate Lucena, again, Strategy and Analytics Officer here at RWC, where I think about all things product design, analytics offerings, and really how we increase the depth with which we're helping our clients think about what their Stars goals are and how to achieve those goals. Just like Brendan, huge tie into the health equity space. I spent about 6 years at Centene Corporation, where I did QI and analytics and data science across Medicaid, Marketplace, and Medicare. And, thinking about health equity was part of the daily job at a company like Centene. So seeing Medicare really sort of go at this hard is satisfying. And I know it's hard for a lot of folks to think about if they haven't necessarily needed to consider it in their Stars improvement strategy. But I'm really excited to see the ways that CMS is pushing into the space.
So 2 people in the weeds, right? With Brendan at the plan, right, guiding this strategy and executing on it, across multiple contracts, leveraging health equity and all the things that we're talking about. Nate, a consultant who is working with a lot of plans around the country. Many of you probably listening. really putting this stuff into action too. So really, really excited to have you guys. Mick, I'll turn it to you. Kind of, you're an improvement measure pro, right? Like it's a big part of your platform, right? What you help plans do. So can you, maybe just give a quick description of the improvement measures and how they're becoming even more important.
Yeah, I'd be happy to. When you think about the improvement measures, or we call them like the unique STARS performance levers, what are those things that are kind of beyond the measures that can really have a positive or negative impact on your overall score? And traditionally, those are the two QI measures, the 5-weighted QI measures and reward factor. And now with the bomb that CMS dropped, a year and a half ago, reward factor going away, HEI coming in, hold harmless changing for QI. The world really is changing. And so to answer your question, Rex, the QI measures, you've got one for part C, one for part D. They're 5-weighted, which in like STARS 2025 terms means every star rating that you improve can add 5 basis points to your score. So take you from 3.8 to 3.85. But when with the member experience weight change that comes in, that adjusts, and now it's 7 basis points potentially. So you're talking about a really meaningful change in a lot of this. And again, maybe just to level set the way QI works. So really what CMS is really trying to measure is improvement across the board, across all of your measures from one year to the next. And so the holy grail is going after that significant improvement category for QI. When we look at this, with the hold harmless change that CMS proposed right now, if your plan scores of 4 stars or greater, you don't have to use the QI measures in your calculation. It's a really significant impact. Just to put a number on it, if that rule, CMS wants to change it from 4 stars to 5. And so if that rule had been in place in STARS 2023, as an example, 36% of the 4-star plans wouldn't have been 4 stars anymore. So this is a really meaningful change, and something that, especially with reward factor going away, something that everybody is going to have to put a lot of focus on. And I'll say, Brendan, we've talked to Brendan how many times about trying to get him on this show, and I'm super excited that we've now finally put it together and he's on here. And I can't think of 2 better people with Brendan and Nate to approach this subject. So before jumping into HEI, Brendan, you guys, as Rex said, perennial top performing organization. And so I assume that you guys have some really focused practices that you might execute on a daily basis around QI, trying to make sure that you're optimizing those 5-weighted QI ratings. So is that something that you can kind of share your experience with us?
Sure. Yeah, definitely. So one of the things that I found out when I first started in this star space, and I was very excited about, when we received our stars rating the first year that I was a stars program manager, I reached out to CMS because I had some questions, particularly about the improvement measure. And CMS said, hey, we'll just send you the spreadsheet that shows how this is calculated. And I thought, wow, I got one over CMS. I won. I have the secret sauce here. And, to this day, I still kind of use that sheet as a model for, our own internal forecasting. But, if you're not doing this as a plan, you can request that improvement measure methodology from CMS. And what we do is we use it to really set targets on a yearly basis for our measures, where we say, hey, this year, let's focus on a measure, let's say the osteoporosis measure, where we don't feel super confident that we can get ourselves to that next star rating because, the cut points are so far off from each other. But can we at least get to a point where we're seeing significant improvement? And using that spreadsheet, just plugging it in to see how many additional gaps you need to close year over year to get that significant improvement is one of the components that we use as we set targets with different business owners across the organization for their different areas. Even, at some of those measures that we hit 5 stars in consistently every year, we're saying, all right, let's maintain this performance, but do you think you can get me another 15, 20 gaps closed for this measure, so that way we hit significant improvement just in case we need that improvement measure.
Yeah, see, and I think I'm glad you brought up the spreadsheet. I don't know that everybody knows that that is available. Feel free to reach out to any of us on this podcast if you don't know how to get that, but it really is a powerful tool that allows you to actually look at your contract and the performance and understand where you likely need to be next year to hit that significant improvement. Do you guys use this also, Brendan, as you're approaching the strategies around MRR, or once you're in process on MRR? Are you looking at this to help understand, all right, we've gotten where we need to be here, but we still need to move, maybe on this measure to help, even if you can't get to that next star rating? I'm glad you said that, because a lot of times, a whole lot easier to get to significant improvement than it is to that next star rating, but it's something to consider and factor as you're working through this stuff.
Yeah, exactly. So, during medical record review, or really throughout the year, but particularly during medical record review, we'll take a look. And I was mentioning getting to significant improvement, but it also works if we see we're in a spot where we had a decline year over year. Well, let's make sure we can do everything possible to make sure this wasn't a significant decline, so that way it doesn't hurt us as much in the calculation. So if I'm still not close to that cut point, or maybe I am still close to that cut point, but because of performance year over year, I'm not seeing as high a performance. If I can get those 5, 6 additional medical records that move it from a significant decline to, I forget the exact wording that CMS uses, no noticeable change, or
no significant change. Yeah,
no significant change. Let's get there, so that way at least we don't hit that -1 on the improvement methodology.
And Nate, when you're working with your clients around QI, do you have certain practices, certain processes that you encourage them to go after?
Well, basically what Brendan already said. So I would, there are lots of organizations that are at very different points on their STARS analytics journey, right? A lot of our clients use folks like Hyperlift, where you can go in and truly have sort of the gold standard of what needs to happen for general overall STARS improvement, but also QI measure improvement, which is, what is your predicted threshold based on what you think your denominator size is going to be, and then backing into monthly targets, right, that you need to hit to understand, hey, am I on track for this, or am I off track for this? While we would all love to have all of the glide paths and all the predictions and things like that, as Brendan talked about, if you just reach out and get those spreadsheets, you can do a lot of damage, right? You can kind of get there with all the formulas that are in there, plugging in different numbers and making some assumptions about what you think is possible for your current year performance, and you can do a pretty good job at driving your strategy using that. And then one other thing I would say is, um, I often don't see folks focusing on the improvement measure early enough in the year. And I totally understand why that happens, right? There's a lot of stuff going on. You've got to be worried about MRR. You've got Caps and Haas in the field. You're trying to spin up your current year, prospective rates and things of that nature. But really setting improvement goals when you set the rest of your goals, and then understanding the interplay between those things, right? They're the two levers that you have to pull that are going to be there all the time, and making sure that you know what your strategy is super early in the year, and not just look at it when you're in chart chase season, right? Not just look at it when you're trying to go into your Q4 push, but understand how to use that to direct your priorities all year is a piece that I see missing more often than not.
Yeah, I think we would probably fall into that camp a lot. Years ago, before the hold harmless change was coming in, if you were solidly 4 stars, yeah, you didn't need to worry about this as much. But the way the world's changing, it really is something that you've got to be far more proactive about this throughout the year to make sure that you're positioning yourself, as well as possible for that end of year push and the end of year results.
Mm-hmm.
Yeah, regardless of your rating, right? So historically,
Yeah.
um, lower performing plans, the guidance it was always, hey, you need to focus on the improvement measure, right? That's your holy grail that's going to get you to 4 stars.
Yep.
Higher performing plans, it was the reward factor, right? It was, hey, maybe you don't have to worry so much about improving as long as you have a high enough mean and low enough variance to qualify for the highest reward factor, right? That was the most important thing because it's half a star. Now with that going away, you can't not focus on the improvement measures, even if you're Brendan, a 4.5 star plan, right? I mean, and like Mick said, with the weight changes. So, right now, or the last couple of years, add up all the star ratings weights and it's about 100. So a 5 weight measure like improvement is about 5% of the overall score. Now, with those weights dropping down to 2 for 14 measures or so, now it's going to be like 70, I forget, 76 or something is the overall weight of all the measures. So now a 5 weight measure is, like Mick said, 7%. So, it's in both of them combined are 14%. That's something you just can't not focus on, right?
Yeah, and I
you've
would
got
say
to.
I try not to let any clients get away with at any point at the level of performance that they're at not focusing on the improvement measure, because you never know what's going to happen, right? You might be on the cusp and something might go haywire in your audit, right? So something could happen. And if you're not paying attention to and optimizing that kind of as you go, then you're probably not going to be able to capitalize or salvage an opportunity if you need to.
Yeah, and I would add, myself, I'm not a statistician. Sometimes getting into the data analytics side of things, I try to stay away from. But one of the things that, I do know is that statistical significance isn't as big as you think it is, or those numbers aren't as large as that phrasing makes it sound. So there are times when you can look at some of the HEDIS measures. I'll use OMW again as an example because that's commonly a small denominator for a lot of plans. It really is 7, 8 members sometimes that will hit that significant improvement. So definitely, I think it's really critical to check that out as often as possible and look early and often.
Yeah, I mean, like breast cancer screening, we look at these numbers, so often for so many different contracts, and it's always shocking to me. You look at that breast cancer screening and what it would take to get up to that significant improvement level. It's typically well less than a percentage point, and that's something that we always try to push to make sure it gets out even beyond the stars team, measure owners. Like, do we understand that? Yeah, maybe we're not going to get to that next star rating, but at least let's push something to get here because it does have such an impact. The switching gears a little bit here, but the reward factor kind of traditionally been known as the 5-star maker, right? And as we saw, if reward factor goes away, the vast majority of 5-star plans are 4.5 now. But then Tukey comes in and changes the game a little bit last year. For the first time in a long time, the reward factor became a 4-star maker. And so that going away is going to have more of an impact on more plans than it would have prior to Tukey coming in, right? And with you guys, Brendan, traditionally high performers probably leveraging the reward factor benefits quite a bit, over the years. How do you look at the reward factor going away and HEI coming in for your contracts?
Yeah, so, like you said, Mecca, as a high performing plan over the past few years, we've been able to take full advantage of that full 0.4 reward factor and have enjoyed it while it's been there. With the health equity index, coming into play over the next couple of years, and that going away, we are really starting to focus in on that social risk factor population that makes up the health equity index and thinking about all of the ways that we can have the most positive impact on those members in order to drive our performance. And, one of the places that we think about that, just going back to the improvement methodology, is as we look at our ways that we can try to get to that significant improvement, If we need to move 10 members into the numerator, well, let's try to make sure those 10 members, or at least 10 of those members, fall within the social risk factor population. So that way we can hit the improvement methodology, we can hit the health equity index, and we're hitting our overall HEDIS or Part D rate, whatever it may be. So it's definitely a major focus here at our plan. I've spent a lot of time speaking with leadership, at a C-suite level, at a VP level, at a director level, at an individual contributor level, talking about the health equity index and trying to explain it in the simplest way possible, but also explaining, how it lines up with our overall corporate strategy and our overall focus on health equity, talking about the overall benefits that there are for focusing on this population, even as it becomes harder and harder to achieve, that full reward that would come from the HEI.
So Nate, that reminds me of some stuff that you talk about often around like the double dip concept. Is that something that you want to dive into a little bit here?
Yeah, I mean, even before HEI, right, you have to keep all the levers in mind and understand, right, where I'm doing work over here and I actually think it's going to benefit me here, here, and here. And the HEI just adds something else into that mix, right? And it kind of can focus your energy a little bit, even if you're not eligible for the HEI, but you do have some of these members, right? Chances are you do have disabled members. You do have members that have LIS, even if you're not a SNP plan. So really thinking about how you may have been leaving those members behind in your strategies. You may have not been paying attention, even though you should. Well, now is your chance to have a business case to do that, right? You now have a business case to do the right thing, whether you're eligible for the reward or not. And go and figure out what's going on in these members. Do we have a lot of disparities here? And even if we're not going to get that HEI reward factor, can we focus on closing that performance gap and benefit ourselves in our overall star and in our improvement measure as well? Because those thresholds are so much smaller than they would be to get to the next star, right? So really thinking about that double dip, and Mick may or may not remember, I made a beautiful slide about this where I had
I remember
one ice cream cone that had one scoop of ice cream and another ice cream cone that had 2 scoops of ice cream. It ultimately got cut from the final presentation, but that was my attempt to kind of get people invested in this idea of a double dip. But it sounds like I didn't need to do that with Brendan because he's already doing it.
No, and I think, Nate, one of the other aspects of the health equity index, and I love that you said that, it's important because it's the right thing to do. You're trying to bring quality care to people who may have been historically left out of the healthcare environment in general. So even if you're a plan that may not qualify for the full health equity index or even a component of it, you're doing it because it's the right thing to do. And one of the aspects that I'm really excited about what we're doing here at Blue Cross Blue Shield of Rhode Island is as we're looking at our broader healthcare strategy and looking at ways to reduce disparities in care between different racial groups or different ethnic groups, we can add in, that focus on, well, hey, what impact does a low income level have on these different racial groups as we're looking at the different activities that we're trying to improve and really drive the focus there. So now, you are helping reduce disparities between racial groups. You're helping reduce disparities between people of different income levels or disability status. You're driving up that improvement measure. You're driving up your overall rates. And hopefully you're getting to a point where you could recoup some of that health equity index score. Or if not, you're hopefully doing enough that will drive your overall rates up high enough to make up for some of that lost, reward factor.
I think that's a really good point, the way you're kind of breaking some of that out. I think everybody's thinking about, with HEI coming in, what can I be doing internally to be able to optimize in our minds, we're always numbers people. Optimize the rates, but how do we best serve this population and make sure that we're giving everybody the best opportunity that we can. Some of the stuff, Nate, I've heard you talk about before is really interesting from my perspective when you think about root cause. So like when we're talking to plans about how do you drive improvement here, I think a lot of us kind of lean to, well, it's just let's focus on this SRF population. But I've heard you talk about it at kind of a different level. You're going down into layers to actually understand truly what's driving this and how do you make change. So I don't know if I explained that well, but why don't you jump in and kind of take that to another level?
Yeah, it was pretty good. This is what I say to folks all the time. Like this SRF thing, right, that CMS has spun up, right? This is just their euphemism for like, this is a benefit flag that we know we can get to that is related to all of the actual things that cause healthcare disparities, right? Dual eligibility is an outcome in and of itself in my mind, right? It is a set of benefits. It's a program for a group of people who need fundamentally different types of care. And that group of people happens to be overrepresented by groups, as Brendan said, that have been historically either not considered or actively mistreated by the healthcare system, right? So in order to fix a disparity that you find in dual eligibles or low income subsidy, it's not enough to just know that it's there. You kind of have to know why. And the reason that disparity is there is probably going to be different depending on your member mix on a whole host of other variables, such as race and ethnicity, primary language, urban versus rural, and sort of the access challenges that poses. All these other different variables are the actual things that you need to aim your initiatives at in order to move the needle in the SRF group that you're worried about. And so one of the things that we see in organizations can sometimes be sort of this conflict between now STARS cares about dual eligible LIS and disabled members, but there's these health equity folks at the plan who have been worried about this for quite some time. And this thing over here, just because it's new and shiny for STARS, should not be viewed as a separate thing from all the health equity stuff that's already been going on and focused on the more traditional variables that we think about, such as race, ethnicity, primary language, all the things that Brendan and I have just talked about. These are in the same ecosystem and they should be playing together in your strategy and in your brains, right? When you think about how are you going to make this program unified, these are not mutually exclusive things. You should be able to have a conversation and sit down at the table with your health equity folks and say, how are all these things interrelated? Because then that brings up the performance and the outcomes for the whole organization.
So are both of you saying, so Brendan, you have two contracts, right? So let's say one contract is eligible for the max HEI reward and one is eligible for none. Are you not treating those contracts differently at all?
No, I think that, what we are actively doing is we are trying to, in a ideal state, we are trying to close every social risk factor gap that there is, regardless if we qualify for the HEI or not. Again, probably biggest, it's the right thing to do, but also we'll see a positive impact on the improvement measure. Because as I was saying earlier, if you only need to get 7 members to move to a significant improvement, if those 7 are all members who fall in the social risk factor group, even better. And we'll also see a overall improvement in our performance outside of that improvement measure. As you look at your size of your denominators, or let's think about the hybrid measures where you have 411. If you get a sample that has a lot of those social risk factor members in it, you'll be thanking yourself that you paid attention to this population earlier on, even if you don't qualify for that HEI. One piece that I kind of want to tag on to, what Nate was saying, as we think about this being a component of the larger health equity ecosystem, for lack of better words, something that I think is really interesting, and I'm very glad that we did this early on, is we worked with our analytics folks to identify who this population is. Um, Historically, realistically, and transparently, when we think about the MMR files, we had never really looked at that original reason for enrollment flag. So I remember when it came out in the proposed rule, and I think all of us were at the same conference in San Diego when it happened, and we all kind of stared at each other and said, uh-oh. But while I was sitting there, I was sending emails to our analytics folks saying, hey, can somebody find this flag in the file, and let's start looking at that. And once we got over that hurdle, we started doing heat mapping, and let's see where these populations are, and let's map this up against some of the other data we have, and let's look at area deprivation index, and let's look at food deserts and public transportation barriers and all these pieces that we're using as we're thinking about outreach, thinking about supplemental benefits and stuff like that as well. We're using all of these data sources together to overall really try to drive a better state of healthcare in the state of Rhode Island, by focusing on some of these populations that we're seeing may have been left out.
So there's, I like the way you approach this, Brendan. I mean, it's very much for, we're doing this for the right reasons, right? And, when we look at this from a analytics standpoint, we're looking at it from STARS math and, how do we optimize things? And frankly, what we've been looking at as we're going into STARS 2026 is, what do you put in place to be able to stay on top of this stuff from a math standpoint? And at least what has kind of resonated with us so far is you're treated almost like you would when you're trying to optimize QI, right? Because you've got three different kind of threshold areas, that you need to be in. And it's like looking about, which of our measures are close to getting to that next one, which are close to maybe dropping, so that we're putting the right emphasis to get the right impact. And so are you guys seeing similar things, like looking at it that way when you're looking at the SRF population and projected thresholds for the different thirds? Is that playing into how you guys are analyzing it?
Yeah, definitely. So once CMS released the data and the hypothetical cut points, the first thing that we looked for was, all right, where are we significantly below? Where are we in that -1 category for the health equity index measures? And we found that in a few spots, and we really put a lot of time and effort into thinking, all right, why is that so? Is it because of a lack of access to providers who do these services? Or is it because a lack of pharmacies, or what may it be? Again, I think, like I said earlier, I'm not the stats guy, but I do feel, just gut instinct tells me that getting a -1 in the health equity index will hurt you maybe worse than a -1 or the significant decline in the improvement methodology. So anything that we can do to move from that -1 to a 0, or hopefully a +1, we're spending our time focusing on that.
That makes perfect sense.
And just to get really, really tactical here as we kind of near the end. So if I'm a health plan, or you're talking to a bunch of health plans, obviously. So if I'm a health plan, where do I start? Am I, with this double dip concept, am I finding the measures where I'm closest to get from decline to no change, or from no change to improvement? Those are the measures I'm focusing on, and then within those measures, I'm digging in to understand which members in those denominators have social risk factors, if I can possibly do that, and I'm understanding their barriers and focusing on that in those specific members in those specific measures. Is that right? Or is there...
It's both and, unfortunately. So like there are if you approach it from the numbers game and letting the numbers like actually drive the strategy, well, two things. Understand your SRF members, full stop, period, right? Whether they're in your HEI, whether they're in the improvement measure, go take a look because it's the right thing to do. Right, figure this out. Um, and understand your member mix in the SRF group too. I mean, people are talking about duals a lot, but at least when we've been fortunate enough to kind of dive into the actual member level data with our clients, your member mix might be completely different than your competitors who's also looking for that 0.2 reward factor in a similar service area, right? They might be mostly SNP in the SRF group, whereas you might be, I don't know, 15% disabled, right? And those are not the same thing. Just like race and ethnicity is not a monolith, neither are SRFs. So you really have to, I would say, become a much more educated consumer of your own data, uh, and 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 know your data and your members really well. Once you do that, though, you have to do both of those things and then put them together, right? And figure out, okay, here's the strategy for improving the health of the population, and here's the strategy for accommodating stars math. And sometimes those are going to overlap, and sometimes they're going to diverge a little bit, where you have to kind of like walk and chew gum at the same time, and that's okay. That's kind of my long-winded answer for that. But Brendan, what do you think?
No, I think that made a lot of sense, Nate. And I think one of the most important things to do is you need to make sure that everybody understands the improvement measure and the health equity index in some way. Um, Not everyone needs to be super in the weeds with it and understand what 50% of the national median means, because I barely do, and I hate saying that phrase, but that's the phrase that CMS chose. But everyone at least needs to understand, hey, here's why we're doing what we're doing. It's the right thing. It drives our performance, and in higher stars performance leads to better benefits, better quality of care for the members that we're caring for. I do also kind of want to steal your wording there, Nate, about the monolith of SRF. One of the things that I've been trying to really wrap my hands around and think about a lot, and I've said this in public comments to CMS, as we think about the permanently disabled flag within the Health Equity Index. There are a lot of things that could put you on that permanently disabled flag or joined Medicare because of permanent disability. It could be behavioral health conditions. It could be intellectual disabilities. It could be a physical condition. You can't treat this disabled population as, hey, they're disabled, here's what we need to do for them. So knowing who your partners are in the community, knowing what providers have experience with different types of conditions, and then knowing where those members sit is a real, large piece of the strategy, and something that I think, is getting slightly overlooked in all of this.
Really good point.
Agreed. Even caregivers, right?
Yes.
Right. Like, do we have a whole other set of issues we have to solve for in a group of SRF members that is is not really present in the other two? So you've got to get there with your understanding your population.
Yeah, I love that. It's like assuming the entire over 65 population is the same, right? And
Right.
like thinking the whole disability population is the same, or yeah. So yeah, great points. Anything we haven't touched on that you guys want to get out there?
Yeah, I think, as we continue to look at this population, the members that CMS have called this social risk factor population, it's important to remember that I'm going to forget which document it was, but in one of the many documents that CMS has put out there, they've talked about the possibility of expanding this population at some point to, as it's easier for them to get data. So if they get to a point where they're able to accurately get race and ethnicity data, we may see that come in at some point, or sexual orientation, gender identity, whatever it may be, we may expect to see that come in. So I do think that as we are, kind of laser focused, or as a lot of plans are laser focused right now on these specific populations that make up the current social risk factor, it's equally as important to apply this current social risk factor methodology to as many other socioeconomic markers that you have. So that way you can see, all right, if I have a disparity between black men and white men in colon cancer screening, here's the disparity between black men and white men with low income status in colon cancer screening. Here it is with disability status in colon cancer screening. Take a look at all of those. Um, and I'm going to sound like a broken record. A, it's the right thing to do, but B, CMS is going to do that to us at some point, so we might as well get ready
Might
for
as
it.
well get moving.
Right.
Yeah.
Right.
Yeah, and similarly to other sociodemographic variables, there's other measures, right, that we fully expect will be included by the time this actually gets calculated. Most of them are around different aspects of utilization, so you should be looking at that right now. I mean, that should be part of your readmissions and transitions of care strategy and your follow-up strategy anyway, but for sure by the time we get there, those measures will have enough data that I fully expect, that they're going to get included in that calculation. So start now, even though they're not in the simulation, right?
Yeah. And
And
I,
one other thing I was going to say is we've spoken about this. I think we've leaned a little bit more on the clinical measures just because there are the widgets that we can count. But do not discount, the member experience. Of course, we all know that it's really important, and in these groups, it is even more important to understand how you should engage again with members who have experienced hardships at the hands of the healthcare system. How do you engage them with trust and empathy and true compassion and dignity in order to facilitate the engagement that we need to improve the clinical outcomes down the road? Don't just go and hammer somebody about going to get a mammogram. Don't do it. You shouldn't do it anyway, but especially don't do it now, right, in the service of equity. Right? Back up and figure out what your members need. What are their expectations? What do they not have? What are their cultural preferences? You have to think about all of that stuff kind of first, right? And then make sure that in a parallel path you're getting your clinical approach under wraps.
yeah. And as we're thinking about, kind of future state of stars, one measure that I definitely have on my radar is the social needs screening and intervention measure. Um, you know, it's a display measure in 2025, so we have some time before it becomes an actual stars measure. But, as you are working with that data and leveraging it potentially to think about ways that you're doing benefit offerings or ways that you're working with community-based organizations, that's another area where taking a look at the data broken down by the social risk factor, population, and other socioeconomic markers, you're really going to see some interesting and troubling things sometimes. Same with the digital literacy screening. While that's not a STARS measure, it's a requirement from CMS. And I can say that, if you're paying attention to that data, you'll see some, real watchouts there that you should be trying to jump ahead of.
Right. Good stuff. Okay, well, we will wrap there. So that's a lot, but such great conversation. So seriously, we could not have had Mick. We couldn't have had two better guests, right?
Totally
To
agree.
have that conversation. Really, really insightful conversation there. So thanks so much, Nate. Thanks for returning. Brendan, so good to have you on for the first time. Look forward to having you on again at some point in the future. So we'll wrap there. Thanks everyone for joining, and we'll talk next time. Thanks everyone.
All right, thanks, guys.
Thank you.